Today, it's Cinco de Mayo. So for Cinco de Mayo, we had to have somebody very saucy, very exciting. And the most exciting person I could think of was Sasha Alexander Rivkin. So in Beverly Hills, there's like Dr. Rivkin, there's Rivkin, there's Rivkin, there's Rivkin, and there's another Rivkin. So there's like all these different Rivkins. This one is the one who is actually very well known around the country for, well, being like the nicest guy ever, and everybody loves him. He's like the coolest person. But he's very, very well known for injectables. So we have very similar backgrounds and training, and then his lifestyle and his practice kind of went towards doing injectables, and he became extremely well known for nasal injectables, doing injections in the nose. Obviously, he's very good at the other stuff, which we'll talk about too.
You know what I just heard? Apparently, and this is something I just heard today. So, sources like always, unknown, but, sounds reasonable. The main ingredient, or one of the main ingredients in crystal meth is,
This is what I was wondering about today.
Yeah, I know you were. I could tell. So one of the main ingredients in crystal meth actually is produced in Wuhan, China.
Oh,
and
okay.
So now that all this trouble is going on in Wuhan, that ingredient is no longer available. So crystal meth has apparently the price of crystal meth has spiked. And so people are,
So when everybody keeps talking about the economic ramifications and the things down the line that are going to be happening, this is what they meant.
This is really what they meant. They can't get the crystal meth. They can't afford it, crystal meth. So.
Yeah. Oh, which is sad. So San Diego was so the crystal meth capitals of the U.S. classically were San Diego and I think Phoenix, Arizona.
Oh.
Yeah. So San Diego crystal meth, I love crystal meth, not for using it, but for pure medical education, like having gone through med school in San Diego. Crystal meth and PCP introduce you to the craziest shit you will ever see.
In the emergency room.
In an ER.
Yeah.
So crazy.
Yeah,
it's so crazy. Yeah. PCP was the most entertaining when I worked on an ambulance, because the last person you want is somebody on PCP, because they're just they get fucking nuts. They get really crazy. So it's a little scary to be on the back of an ambulance with somebody on PCP. But meth was oh man, San Diego was a very interesting place for the ER. Much crazier actually than New York. And in New York, I was at Columbia, which is in Washington Heights, the Dominican Heights. It's that was a pretty rough area too, but nothing like San Diego.
Very interesting. Yeah, because I went, I did my residency in San Diego.
So
I remember that. I fortunately, I remember that ER. Fortunately, my experience trauma-wise on there was minimal. Thank
really?
God. I didn't get the trauma rotation, which is. But I still was getting there for neurosurgery and all that kind of stuff. But I would spend a little bit of time in Texas.
Mm-hmm.
I gotta say, in Houston, anything we saw in San Diego is like nothing compared to Houston, man. There's some crazy stuff that was going on there.
Yeah.
But
I'm sure.
That's interesting that I would imagine that Morningside Heights would be, intense.
Yeah, it was. And then, USC, I did a rotation there. That was obviously county hospital where you have, because they have 4 ERs. They have the ER for the prisoners. There's a psych ER, and there's 2 regular ERs.
At Columbia?
At
168?
No, at USC.
USC.
Yeah, USC. Yeah. Columbia had, we had 4 or 5 ERs, and then you had the pediatric one too. But people were not nearly as crazy. The people going into San Diego were just nuts. They'd come in nuts. They're just whipping their stuff out. They were crazy. Or you'd have, San Diego all the time. They'd say okay, we have another trauma coming in. We have another trauma coming in, and the trauma would come in, and they're okay, well, we have a pregnancy. We have a 12-year-old with a gunshot wound. We have da-da-da-da-da. And they come in, and you're oh, shit, it's a 12-year-old who's pregnant with a gunshot wound.
Oh, and on PCP.
And then the other trauma bay is the guy that shot her.
Yeah, of course.
And so you have both of them, and then you have to shut everything down. You can't let anybody in the hospital, because the members involved are trying to come finish the job. Like,
Yeah,
it's like,
naturally. You can't let
yeah,
any job to the time. These guys are professionals. They don't want
yeah.
to, they don't want to mess around.
Yeah, and that's what they taught us when I was I drove an ambulance for a couple of years. This is like when I was in like ski patrol, private investigating, an ambulance, and I was like going back and forth between the jobs, and
Wow,
it was like a fun time in my life. And
that is a fun time.
the ambulance part, the first thing they taught us was, just so you know, we work in Compton, because I worked in Compton and Inglewood and Carson. Also, Carson was pretty bad,
Yeah.
and they're like, if you're there for a gunshot wound, you don't go save the person unless the police say you can go. And like, trust me, you're going to want to go, but you can't go unless the police say you can. Why? They're like, well, somebody was trying to kill them. And if they didn't kill them, they might still be trying to kill them.
Kill them.
And these guys have like years of experience. They're like, dude, you don't know the shit we've seen. They do come back. And the hardest place to work was Compton, not because of the violence necessarily, but because the projects then were all very, very difficult to navigate through, because the numbers are all the same on all the buildings. They all have these weird, it's not a normal address. They have project addresses.
Okay.
And you can't find where you're going. And we didn't have navigation. We had a Thomas guide.
Right.
And so you go, and there were a few projects that we knew really well, but you'd show up and there'd be 4 other ambulances there for 4 other calls, and you can't figure out like what to do. And and you couldn't leave your keys in your ambulance, because people like sometimes they take them. Sometimes they move your car for you, so you usually do have to leave it. But there's a button on the ambulance now that you can do to turn it on to get it to move. But either way, that's all.
Oh my God, that's interesting. That's much better than most people's, like, I was working in a lab and like with mice and stuff like that. This is it's much more interesting job history.
But there's no scarier rotation than OBGYN at the Navy hospital. Like the hierarchy. Really? Oh my God. Well, OB is already known for a very difficult rotation to be in because of the hierarchy that exists. Imagine you add on military hierarchy, sprinkle some estrogen on it, like really strong. It was that was rougher than everything. It was fun. I loved it. And I loved the people there. Like, the Navy patients are the best. Yeah. But the OB docs, that's like, they're the only ones I think that are like harsher than neurosurgeons. Like, they're really harsh sometimes. They're rough.
Interesting.
But what I really want to talk about was your nose. So. Okay.
I do take a lot of pride in those things. I mean, it took generations to get to this, this prominence.
Yeah, it's a beauty. It's a masterpiece on top of a masterpiece. So the thing I wanted to, there's so much that, like, I think you're more than just a nose injector. So I do want to talk about a lot of things, but I think we should start with that. Sure. Because everybody's always curious about nasal injectables, non-surgical rhinoplasty. And I think 2 things about it in general all the time that are in my head. I think that injectors go way too far with it. Yeah. And I think that injectors talk way too much shit about it, and they're too scared of it, which they should be. But, those are the 2 things that I think, and I wanted to kind of go through, like, your thoughts on, first, like, who you do, which noses you like to do, and then how you relate that to surgery, and then we'll go over all like the risks and stuff. So what are your kind of like limitations on what you like to do on a nose? So everybody knows we're talking about fillers on the nose.
Right. So we're talking about fillers in the nose. We're talking about non-surgical rhinoplasty. And it's something that, it's become a really hot thing with Instagram, because the befores and afters are so dramatic. It's such a visual thing that people will really want to do it because they feel like it's going to get them attention on Instagram, and it's going to jumpstart their practice. Mm-hmm. And that's problematic, because of all the things that we do in terms of injections, that's by far the most dangerous one. Anywhere we go in the face, it's the nose it's the nose that's really the most dangerous in terms of various things. One thing is the things that we really are scared of is ischemia, necrosis, damage to the skin and tissues underneath it. And also, of course, we're very concerned about the cases, very few cases and very rare cases, but still nevertheless cases of blindness.
Yeah.
And that is something that we, that can happen. I mean, these kinds of things, ischemia, necrosis, blindness, these are the complications that are really the most severe in injections, and they're very, very rare. But they can happen anywhere in the face. But anywhere on the face, yes. But in terms of risk, the nose is the highest risk. Because, and why is that? Because, as you know, the blood flow to the skin of the nose in certain areas, like the tip and the ala, is not as redundant as the blood flow to other areas of the face. There's just not as many vessels feeding those areas of skin.
Yep.
So if you put filler underneath there, and let's say you get it into a vessel, or let's say you just kind of, you put enough filler in there to squish down the vessel, to put pressure on that vessel, compartment-like effect, you can really actually, you can jeopardize the blood supply to that specific area of skin and damage it. So that's really most so in the lower, in kind of lower face, in the lower nose, so the tip
Right.
and the ala and the columella, right? This is it, this area. So that's why that area it has some danger. And then, but when you go up here, you're talking about, you're next to the vessels that come out of the ophthalmic vasculature, right? So you're in the air, you're very close to that spot where, and those are highways back into the eye. And that's where people can really get into complications such as blindness. So the nose is a place that you should only be injecting if you're an expert injector.
Yes.
Especially people who have had rhinoplasty before. Those people, you should be only injecting those if you're an expert nose injector. And there's not a lot of people who do noses all the time and should be doing that. So I think that it's a great procedure. People are really happy, but you have to really watch out. You have to know what you're doing. You have to know the anatomy, know how to, have control over injections, have the right techniques before you do something like this.
Yeah. And so I think like the basic anatomy or kind of physiology, just for everybody to understand, is we're adding volume in certain places to diminish the appearance of volume in other places. That's like the basic kind of idea.
That's the basic thing.
Yeah.
And the thing is, the interesting principle is that, people talk about, oh, you're adding to the nose, you're adding to the, you're making it bigger. But the thing is, you have to think about the optics of it. And as you know, how the eye looks at the face, the eye wants proportions, and the eye wants everything to blend. If you have a nose with a bump on it, or you have a nose with a curve on it, what the eye wants to see is a straight nose without bumps or without curves. If you have a bump or a curve, it attracts the eye and makes the nose look bigger than it actually is.
Yep.
You add to it and you make it straight, it blends into the rest of the face, it makes the nose look smaller, but it makes the nose look smaller because it's straighter and it blends in. Right. So those kind of principles are what we kind of, what we work with to get the kind of cosmetic effect that we really want.
Yeah, and as far as risk and limitation goes, so for how I teach people, like when they come in and they want to see how to do nose injections, I try to explain to them that you're always better off saying no to somebody in nose injections than doing it for bad reasons or trying to like get away with something. So first off, the fillers are not cartilage. So get rid of the idea. It is not a rhinoplasty. So people go in and they think it's like a rhinoplasty where, okay, well, I learned the cartilage is here. Let me replace some of that structure and put the nostril down. It's not rhinoplasty. This is a skin and subskin camouflage game where you're just kind of volumetrically adding, getting rid of a shadow, doing this kind of stuff. You are not replacing structure. And sure, sometimes you do it where, in the mid-vault here where someone's collapsed and they can breathe better. Fantastic. But it's not replacing the cartilage. So you're very lucky. Every time I do a nose, I'm like, okay, good. Nothing, it is a higher risk area. And the biggest thing I say is you never fill an area that has no dead space. So if you can stretch something very easily and you're staying in the midline, you're more safer.
You have more. I mean, there's never any guarantees. There's never anywhere in the face that you're totally safe because there's anatomic abnormalities everywhere and there's vessels crisscrossing all over the place with connections all over the place. But relatively speaking, if we're talking about the side of a nose where the angular artery is coming up versus on top of the nose in the midline, you're safer on top of the nose, the midline. So statistically speaking, that's the place.
Yeah. Yeah. So I tell all the injectors, I say, if you're going to get into this, take it easy. It's better for a rhinoplasty specialist to do it because we've seen the anatomy and we understand where the SMAS is. And so for people who don't understand, there's your skin directly underneath it. There's no big fat layer. There's no big muscle layer. It's a very thin layer of fat, very thin layer of SMAS or musculature. And then underneath it, you have some periosteum and cartilage and stuff. In that higher layer where the muscle is, you have all these vessels running there and above. So anywhere where you see muscle, you see vessels. And that's where you have to be careful. So you have to know the depth of where to inject. And also not injecting in dead space and not injecting in watershed areas also without being careful. So the watershed areas increase after rhinoplasty. So you do a rhinoplasty and these vessels come and they meet in the middle. That middle area is a watershed area because it has perfusion from around it, not directly from vessels sometimes. In revision, now it's been cut off. Now you're a little more at risk. The other thing is adherence increases. So this area, which was not a risk before, everyone's like, oh, I can just inject the dorsum with no problem. Not so on a revision. Revision, this can adhere. And once it adheres, if you inject it, you immediately can compress a vessel. You don't have to go into a vessel. You just compress it. And those are scary things. And you try to, avoid any kind of pressure injection or anything like that. So when I teach people how to do it, I'm always scared. Because I don't want them to go start injecting willy-nilly. You want them to really be careful. And the other thing I try to get through is volumetrically, you got to be responsible with this. So before we get into products, I want to ask you about volumetrically, a big problem I've seen is people don't understand that it can cause a tissue expansion effect. It can distort cartilage. It can stretch skin. And it can accumulate water. Those are the properties of the filler, especially in the nose. So when I see these noses, especially on Instagram, where they take this nose that's completely taut, completely down, completely big hump, and they went and made it totally straight, brought it all the way out. I'm like, oh my God.
Yeah. They lose the forest for the trees, right? Yes, it's straighter. Yes, that's true. But is the overall effect really an aesthetic improvement? And they're so focused on getting that shot.
That lateral view.
That lateral view for Instagram, that it's like everything else goes to hell. And it's, aesthetically speaking, the whole picture suffers.
Yeah. And I would say if you're going to live only 5 more years and you're going to live that 5 years in this direction, I'd say, okay, you can go ahead and do that. But realistically, what's going to be happening is that you're going to start getting a droopier, more expanded, fatty-looking nose over time because the fillers in the nose can accumulate. They can actually build up, and bring in more water. And there's certain fillers that do that more than others. So I hope that anybody who does injectable rhinoplasty does very small amounts, very responsible amounts, not dumping. I've heard people come in, they're like, I use 2 fillers in my nose. I'm like, what the fuck? What are you talking about? You use 2 fillers.
What does that mean?
I'm like, oh my God. So
no, I agree with you, and that's so I've modified my technique for those specific reasons. So now I don't take the syringe as offered and as it's sold. I transfer it to a BD diabetic syringe. So it's a 31 gauge needle and a 0.3 cc syringe.
Nice.
I think it's more comfortable for the patient. It doesn't hurt as much because the needle's smaller, and also because of the smaller syringe, your pressure of how much of when you're injecting is less. So it hurts the patient less. The other thing is that you're injecting smaller amounts.
You don't like hurting people?
I don't. I know. It used to in the past. Back when I was a young man, that was a good But now the thrill is gone. The thrill is gone. But now, and also, if you're injecting less, you have this little tiny needle. I can inject 0.0, I can inject 0.02 cc bolus, which is really tiny, but it's all I need to make a little dot, and that really kind of shapes and sculpts, and that's that precision, especially in the nose. You got 1 millimeter going one way, going in the wrong direction. You really have a problem aesthetically, because the nose is so aesthetically sensitive to asymmetry and to any kind of deviation. So you want to be as precise as possible. And this is the way, so what you're saying is right. Small, like very specific control of how much you're putting in and where, absolutely critical. Like no question about that.
And, you know, I always think about kind of the long-term effects of filler sitting there. And it is reactive and can draw in water and do all that kind of stuff.
Well,
so,
actually, I wanted to ask you about that. As a surgeon, as somebody who's operated on most likely quite a few noses that have had filler in them previously, I was talking to, and I mentioned this before, I was talking to Richard Zamalian, and he was saying, because he's operated in a few noses that I've injected before, and he's saying that it's interesting because he's like, the patients come in, it's 3 years after your injection. I think I'm okay. I do the operation. It's still there. It's interesting.
Of course.
The jelly is still there. It's much longer lasting than we think. We think it's gone in a year, but it's not. Even though the cosmetic effect may be quite diminished. Yeah. But it's still sitting there.
So that's always my concern with filler. Cosmetic effect goes, but the negative effects of water retention stay. And I see that a lot with under eye filler, mid-face filler, and upper lip. And upper lip, again, like the most notorious, highest migrating filler of all time is Juvederm. And you see it with that kind of crawling up here, even in small amounts that you injected down right here. Okay. So the filler cosmetic effect is gone in a year, completely gone.
Right, no question.
2 years later, they look monkey-ish. And their lip doesn't function as well. And when they smile, they get a bulge. And it's because it crawled up here. And in certain places it retains. So this is a retention zone. The under eye is a retention zone.
That's for sure.
Because it's reactive. Either your body encapsulates little micro beads, or it just doesn't get rid of it because you don't have naturally occurring hyaluronic acid in some areas.
Right.
The less naturally occurring hyaluronic acid you have, the less I think hyaluronidase actually, your natural hyaluronidase goes and turns over the material. So the under eye specifically is an area that you don't really have much hyaluronic acid naturally existing because you're dealing mainly with fat and fascia and periosteum. So there's not much in there. There's a lot in the SMAS and a lot in the dermis. So this area in the lip, I see it retain, and it retains 10 years. So it's things from 10 years ago. Under eye, easily 10 years.
Easily 10 years. I think that's true.
When you get in the nose, the areas that you see that it lasts is mainly the radix. So in the radix itself, and it's most likely because of the drainage pattern, things tend to gravitate down and then accumulate there.
Right.
And radix is the one place that's sensitive to the filler type more than anywhere else, because let's say you use Juvederm versus Voluma. Voluma, not going to cause a problem, doesn't bring in water. Juvederm here, some people, they'll start getting a heavy glabella 3 years later, 2 years later as it comes like this and widens. And it's kind of like those silicone injected noses. So I
don't understand that, like why people do use that is the thing that really kind of isn't clear to me. I guess people are scared of the injection. People use Juvederm in the nose. I don't think that's a terribly great idea.
I would go a little. It's a horrible idea. Yeah. You're nice when you say things. It is a horrible idea. Everybody does things differently. In my hands, this. In my hands, that. Yeah. No, in my hands, if you take a shit on somebody's face, there's shit on somebody's face. Like there's no way to not. I wipe it off. There's still a smear. Right. So Juvederm is one of those things where, yes, it is fantastic for Juvederm, meaning like derm rejuvenation, dermal stuff. It is a horrible filler for the nose. It is a horrible filler for the under eye, and it is a pretty terrible filler for the lip if you have other options. If you have no other options, fine.
I agree with you.
So it migrates too much. It brings in too much water, and in areas that are sensitive, or because this area will keep retaining it, and they end up with this thick glabella, and it's really not sexy. Terrible. Yeah. So product choice. Everybody says in my hands. Yes, I understand in your hands. There is a lot to say for product choice, and if you don't know that, then in your hands you're not going to be getting the best results, because all these products are very, very different in how they react. Yes, they're all hyaluronic acids, but they have different reactivity within the face, and you can attribute that to hypersensitivity. You can attribute that to migratory patterns, hydrophilicity, capillary, crawling, whatever you call it, whatever you want to call it, capillary tension. But they have different reactivity. So I think there are products that are good and bad. So going through those products, my favorites, I like to use Restylane Lift and Voluma. Those
Clearly.
are kind of the easiest,
Absolutely.
most bang for
I
your
agree.
buck.
Right. They don't retain a lot of water. They stay in place. They more or less have a decent G prime, although Lift has a better G prime than Voluma, but Voluma lasts longer than it seems like cosmetically than Lift.
Yeah.
So there's a bit of a trade-off in those two things. But yeah, you're right. They don't retain a lot of water, and you can sculpt with them. You can make edges. You can make shapes with them, which you can't make with these softer fillers.
Correct.
And so it's yeah, I mean, I think that's a no-brainer that those are the two fillers, temporary fillers that I think really, you know, and they're still reversible. So you have that peace of mind that if, you know, by chance that this one, you know, one particular area absorbed more water than the other one, you can always bring it down. You know, patient decided, oh, you know what, I actually don't like this. You can take it away. And that's, I mean, it doesn't happen that much, but you know, sometimes it does. So those are the two I really like.
But doctor, I don't want to keep injecting it every 3 months. What's your
every 3 months? Yeah. Right. I'm like, you get 2 years out of it, fucker.
Yeah, it lasts a long time.
Yeah.
Okay, so let's say you explain that to them, and you say that a lot of people do have an accumulative effect where you add a little more, and it seems to last longer and longer every time you do it. They get that part.
Right.
And then you explain to them there's also a potential negative effect of having fillers sit there and draw in water. If you have too much filler in the nose and it expands and congeals sometimes like it does in the tip, they get that part. How about the general other problems? When they say, I want something longer lasting, and this doctor said I could do Radiesse, Bellaville, Artefill, Aquamed, or silicone.
Okay. So this is interesting. So I did the study on Aquaman. I was one of the investigators in Aquaman, and there's a reason why it's not FDA approved. So yeah, Aquaman unfortunately was problematic. Even in small, I mean, we had like 20 patients, and we had a problem in 2 patients where we really, you know, we couldn't get this thing this nodule kept expanding and, you know, contracting and traveling all over the place. It was horrible. It was a real pain in the ass.
So before you said, so my grandma is watching. She just gave a smiley face. I don't know how she knows how to do that. But let's say if you're explaining, what is Aquamed? Because my grandma doesn't know.
It's a hydro. Wait, what's it called? I forget what it's called. What that substance is called? The class of substances.
Yeah, they're.
I'm blanking out. Yeah.
So you have PMMAs are this way. Those are it's a silicone-based gel thing where they're
hydrogel. It's a hydrogel.
It's a hydrogel, but it's there's another word for it with the it's not a polyacrylate, but it's
No, it is. It's polyacrylamide.
Polyacrylamide. There you go. Not polyacrylamide. Yeah. Polyacrylamide. Okay.
Thank you, Google. Now we look smart.
So polyacrylamide, I group everything that's polyacrylamide, everything into silicone. Yeah. I just put them silicone because they have the same kind of duration and everything like that. So, but what's the problem with doing something permanent then?
Well, I mean, it's interesting. I have to say, I actually use Bellaville. I'll use Bellaville on my noses. Again, very small amounts. I'll bring them back 3 times. I'll just add a little bit. And Bob Kotler does it, you know, does quite a good job, seems like, with silicone, with, you know, again, very, very tiny droplets and stuff like that. So I think that, again, I think there's tools. There's good tools and bad tools, and there's tools that you know how to use and tools you don't know how to use. Yeah. And so if there's Aquamed, I think is a bad tool, right? Don't use it. All these polyacrylamide, like I haven't seen a polyacrylamide filler that is good. I mean, I haven't heard of one. We don't have any approved in the FDA, but even abroad, I don't know if has any of them any good? No. No.
So all of them have lost FDA approval for most things. All the silicone and everything in that range, they had left them. The last FDA approval was 2 years ago, and that was for nasolabial folds and acne. And they started losing the approvals for that too. And the reason I think they did that was because the nasolabial folds are generally a very low sensitivity place. So it's really low chance they form those granulation tissue granulomas, nodular problems. And the acne skin is so damaged already that when you're doing subcision and injecting it underneath, like, okay, how can you make
what can
that
go wrong?
what can go wrong? It's already so jacked up. But they've lost those approvals too. So when you're injecting that stuff, it's kind of off label, which is why I tell everybody this is something that literally two injectors in all of Beverly Hills should be doing.
Right.
That's
so,
the highest
exactly.
of the highest of the level of training. And you've seen things go wrong a million times.
Right. Yeah.
And I've seen things go wrong a million times, and we're scared of not fixing it. So I would say there are very few people that should be doing it. And that's like the people like you who this is all you do forever.
Right.
And Cutler's been doing this stuff forever.
Right. Yeah. So so Bellaville, I think, it's a very, very specialized tool. It's a tool that, it's a filler that seems to last quite a long time. It's methyl methacrylate with collagen. It gets its effect by generating kind of collagen or whatever connective tissue. And so usually people, it sits under the skin. Usually people need a touch up after like 7 years, 10 years, sometimes not, but depending. But yeah, you got to know how to inject it, and you got to know, again, if you're going to do, that's another thing, like redo, like post rhinoplasty noses, leave it to somebody who's like does non-surgical rhinoplasty all day long. Leave it to that people, because you don't want to deal with the problems. Permanent fillers in the nose, leave it to those people too, because if you've got a problem with a permanent filler, there's no hyaluronidase. There's nothing you can do. There's no fixing it. So you got to be very, very sure of what you're doing.
And so people understand from what I've seen from the permanent fillers from Kotler especially too, he's using them in the tiniest amounts. You're not doing those big humps, big this, big that. It's actually like somebody who has just forever had this little indentation here, and you're like, okay, well, I can operate on it, or I can do this tiny little speck of filler in there. The chance of that speck of filler being reactive and causing a problem is very low, versus a giant aliquot is huge. So people also don't know that it's very volume dependent on what you're doing. So let's say somebody comes in after a rhinoplasty. This is where I've seen in Beverly Hills things go wrong with good injectors. Is the person just had a rhinoplasty a month ago, 2 months ago. They're on TV, and the doctor sees an indentation on one side. Not the best of surgeons, not the worst, like amongst the popular ones. And this has happened many times, not just once. And the actor or actress or reality person comes in crying because they injected their nose after that first month or 2 months, and they became ischemic. And the doctor's like, I don't know why I became ischemic. How did I become ischemic? Why that happens, obviously, is because you just elevated the skin and you're putting it back down. Your blood supply is worse. So you're more sensitive to these things. And the vessels themselves can spasm a little more easily during that time too. So how long do you wait after a rhinoplasty in general? Do you have like at least 3 months, at least 6 months?
At least 6 months. At least six. I think at least 6 months. Ultimately, everything's changing. As you tell your patients, I'm sure that everything's changing up to a year. So don't make judgments on the results until a year has gone by, right? So I think, ideally it would be a year, but up to 6 months. I think 6 months minimum is good, because you want to see why you want to spend money. Let's take it down to sort of the most basic level. Why you want to spend money on me when in 6 months all by itself it could actually correct itself and be fine. There's certain. Obviously the situation's different, but you want that tissue to recover. You want your nose to you want health. You want to be injecting healthy tissue. You don't want to be injecting tissue that's still healing and can get into problem.
And I think part of it too, fortunately, my patients don't ask for that because I warn them so largely beforehand. My whole conversation beforehand is about recovery time. So that way, after when they're recovering, they just remember, okay, well, I don't remember anything you said to me, but he did spend the whole time talking about how long it's going to take to heal. And there's a big benefit in that, because they're not panicking trying to fix something, or at least they're panicking but not trying to fix something. They know they're stuck with me, and I've been through this, and I'm going to guide them through it slowly and do things in a smart order, not
Yeah.
in like a panicked order. You don't want your doctor to be a panicked doctor and like,
That's for sure.
oh my God, I gotta
Yeah.
inject this kind of stuff. And I try to
Yeah.
explain, my patients, like, they tell me all the time, I'm concerned. I go, I'm glad you're concerned. That's fine. You can be concerned all you want. You
Right.
should be really concerned if I'm concerned. I
Yes.
go, if I'm like, and I'm not, telling you that lightly. I'm serious. Like, if I'm
Right.
worried and I'm panicked, I'm not holding anything from you. It's your body. I'm not going to lie to you. I'll tell you what's going on. It's not like I'm
Right.
keeping a deck of cards. I'm not, a politician. I'll tell you exactly what's going on. But you can be concerned when I'm concerned. But it is smart to wait the right amount of time before doing it. Now, what do you think about fat injections in the lips?
So
'Cause
actually,
I'm kind of moving. Oh yeah. Mm-hmm.
I think it's interesting. There's a question that's actually quite interesting. How can you inject cortisone to your nose to make it smaller, and how long does it last? I wish. I mean, I've tried it, right? Because it makes sense to me. I'm like, oh, well, okay, we're going to shrink down scar tissue. We can inject cortisone to shrink down scar tissue. Well, maybe there's some scar tissue under the nose. Maybe I can just like squirt some cortisone in there. Maybe that'll shrink it down. It hasn't, unfortunately, empirically speaking, it just hasn't worked that well.
It hasn't worked. Yeah. So cortisone is widely used for a lot of things. Cortisone, what we're talking about is triamcinolone injections, which is it's like a calcineurin inhibitor, I think, but it's like it's a steroid type medication, and so is 5-FU, which is more of an immune modulator. And we use these things to take down swelling and inflammation. Cortisone itself is one of the most damaging substances you can inject into someone's dermis, into like right under the skin. So when we inject it, and I inject it in the nose sometimes, I inject it sometimes deeper into scar tissue after a facelift. We inject it deep, and we hope that it's just going to diminish that amount of actual scar tissue formation, whatever you imagine the scar actually is. Right. But we see largely damaging effects when people inject it either too much concentration, or just, bad luck with it, because it does happen where you inject, you shouldn't be injecting pimples with triamcinolone. Like pimples, they atrophy forever after triamcinolone, whereas if you can do a dot of 5-FU, it's fine. Yeah. Those kind of things. But just so everybody knows, the cortisone shots can leave permanent indentations, and before doing that, they can discolor your skin. And if you have discoloration on your nasal tip, it'll look like you have an indent, even if it's just discolored, because you have a shadow falling there. So very careful with cortisone injections. Don't use it as like a mode to try to shrink things, but certainly after surgery, it's warranted. Like you do it, especially on revisions that have had a lot.
And sometimes people have some scar tissue that can be reduced, that where you can use it very gingerly, very carefully. And I think, I agree with you, in as small concentration as possible.
Yeah, and I've seen it work magic for supratip scar, where somebody had a blunted supratip. They look like they were hooked. You inject it 2-3 years after their rhino, all of a sudden it shrinks down. But you could feel those. And it doesn't mean it's not going to reform. It can reform because it formed in the first place because of the dead space. There's probably too much skin for that infrastructure of the nose, so it might form again. But the place where it's like permanently damaging, and I'm like, where did that big hole come from on your rhino, like on your bridge? And they're like, someone injected cortisone there. I'm like, what? Someone, there are places where you just super careful.
Yeah,
super careful.
That's true.
So what do you think about fat? Because that's another product that people have been using in the nose. And I've seen a couple cool results where somebody had a little indentation and they got like a globule of fat and injected it just like you would with the Bellaville stuff. And I've seen horrendous, irreversible fat glabellas.
I don't understand. I don't understand that. Fat, there's no way you can get precision. There's no way you can get an equal amount of precision with fat as you can with fillers. There's no way you can get reversibility like you can get with fillers.
Also correct.
And it's so unpredictable in terms of, how long it's going to last when you inject it. So we have fillers that last for 2 years. Well, I mean, I do a touch up at 6 months, and then that gets me about 2 years with Voluma. So, and then I have fillers like like Bellaville, where it really lasts a long time. So I don't see the point of fat. I think it's an inferior tool.
Yes.
I think fat, right?
It's a nice way of saying it. It's a very nice way of saying it.
I try.
I agree. You're much more diplomatic than I am, but it is definitely an inferior tool. And, I try to explain to people when they tell me, well, doctor, I want something permanent. and I want something natural.
Yeah.
Okay. It's not natural to take fat out of your ass or your abdomen and put it in your nose. It's as natural as taking your eyeball and putting it on your toe. It's
Right.
like, it's a different area, and it doesn't
Right.
naturally exist in that area. So as far as natural goes, it's not that natural. Okay. It's natural because it's your own body. Great. I
Right.
get it. But it's in a different location than it naturally exists. So natural, we can kind of put aside. And then as far as permanence goes, I go, okay, well, you know what? Permanent's a good or bad thing. Like, yes,
That's true.
if you get lucky with it, it's great.
Yeah.
But what if it's permanent in a bad way? You know,
Right.
that's permanent. It's very difficult to get rid of. The fortunate part of a lot of these glabellar fillers that leave a lot of volume, and so I do all revision rhinoplasty, right? I'm not the lucky Raj Kanodia or Zumalin who gets primary.
Just a little shave off the top, and you're you're a genius.
Yeah, you know, I don't have those. There was a meme I saw the other day that's like, when the devil can't reach you, he sends you a Latina. And then I looked at it, I'm like, well, also a revision rhinoplasty plasty practice, which I love revision rhino, but you have all these other things to deal with. And one of them now more than ever is fillers and fat. And we didn't see it so much before, but now we see it. And fortunately, most of it is actually injected in the right spot, which is that they go super periosteal.
Yeah.
And even if they didn't tell me before, and even if I palpated the nose, I mean, like, there's a low chance I'm not going to palpate the nose now and feel it. I know that doughy feeling that we all know. Yeah. We're like, oh, your filler's still there. You know, I know that feeling now. But there are a couple that got past me, and I didn't know. And I didn't dissolve it beforehand because I like to dissolve them beforehand. And I like to dissolve them way before so they can rehydrate too, because otherwise that SMAS layer gets really thin, and then afterwards you can get lumps and bumps, and it's also more difficult to dissect in a proper plane. So I like to do it before.
How much time do you like to leave?
If I can do it. So everything else in the face, like lips, I do so many lip lifts. I'm like, come to me 2 weeks before if you can. I'll see you again 4 days later to do the second round of it. And then we wait a week. It rehydrates a little, and I'm not as miserable ripping your SMAS off your muscle. Because anytime the hyaluronic acid is no longer in the SMAS layer goes from, and the face too, the SMAS layer will shrink from this to that. It becomes paper thin. The SMAS carries a lot of hyaluronic. Everybody's like, it's in the dermis. No, there's a lot of hyaluronic in the SMAS. Okay. And it also provides hydration, and hydration gives it this greasiness that allows your tissue planes to spread. Yeah. So same with the upper eyelids. When they inject hyaluronic acid with their lidocaine, it's way harder to strip off the skin off the muscle because you don't have that glide plane. Rhinoplasty is the same. Okay. And either way, but what I've noticed is you can get a 7 French Fraser tip, and you put it in there like you're doing liposuction. Once it's open, you open the nose. Yeah. And you pop it in there in the open plane that your Alfric is going in, and you can actually just suck that stuff out some of the time. Yeah, and it comes out substantially, and you look at the nose from the side, all of a sudden the hump's there again. I'm like, oh my God, that was a lot of filler. Right. And it takes 2 seconds, and it's easy to do. So we're fortunate in that sense. Rhinoplasty and fillers are 2 different things. So everybody says, well, I don't know if I want to do rhinoplasty. Let me try filler first. How do you guide people through that as to let me try it?
Right. And I think there's just one quick question in here that I wanted to address real quick. Somebody asked about fat injection under the eyes into the tear trough area. And I don't know tell me what your view of that kind of thing is, because to my mind, that is, I think, kind of similar to my view of with the nose, is that we have these fillers. If you do hyaluronic acid into the tear troughs, if you do it right, you can have a result that lasts you for possibly for like ever. Like it doesn't go away. Right. So when you have a tool like that, that's reliable, that's reversible, that lasts for such a long time, fat, there's just some unpredictable, unless it's a large volume that you need to get in there. They're very, very deep. Tell me what's your philosophy about that?
So it's a conversation I have all the time. So I do lots of under eye fillers. I do lots of lower eyelid surgery. I do lots of mid-face lifting. So I have this conversation all the time. And I try to explain to them, I say, filler and fat are 2 different things. If I'm trying to correct you non-surgically, filler will get me farther more safely than fat can, because I can't push fat to that extent. And the reason I can't push fat to that extent is because it's a reactive substance. It can act like silicone. It can hypertrophy. It can get nodular. It can granulate. All these different things can happen, which are different disease processes. And it can also draw in water just like all these other fillers can. Fat can do that.
Right.
And people don't get that. They say, what do you mean? But it's natural. I go, again, taking fat out of your ass and putting it under your eye is not natural. It's not natural. I get it. It's your body into your body. It's not natural. So anytime we do it, and I do under eye fat, and I do under eye fat, I'm so happy I got away with it. I'm looking, and I'm not looking at 1 year later. I'm talking about 5 years later. Okay, I'm worried 5 years. I'm like, because 5 years is when this stuff happens. You put silicone in the lip, it's not going to cause a problem the first 4 years. It's the 5th year.
It's the 5th year.
Same with fat. It takes a long time for this stuff to cause problems. So when I do it every single time, I'm thinking to myself, I don't want to go another 5 years in practice and then come back and be like, oh my God, holy shit. I just made this person look like a mongoloid because they went through menopause and they had hormonal fluctuations and their fat hypertrophied.
Right.
Or they gained 100 pounds, their ass got bigger, and then their eye got as big as their ass.
Right.
So when I do under eye fat, I do conservative amounts. Like if you look at my brother's photo, my brother, I did a little bit of under eye fat on him.
Okay.
Very, very small amount, built it up in a very super periosteal plane, maybe right above that, right below, like in that SUF area, and I keep it safe. Filler can get me farther. I can do more with filler as far as correction goes because, first of all, it's a different substance. I can go more superficial with it, deep with it, here, there, anything I want. And if something goes wrong with it, I can reverse it. 2 years go by, your effect's going down, but you start retaining water, I can fix it. I can fix all that stuff.
Right.
And then I say, okay, well, what if you want a bigger result? Well, if you have enough fat, now we've seen that the majority of long-lasting improvements in the under eye come from fat repositioning, not from skin tightening, not from this and that, because all those have negative effects that can shorten your eyelids, and you get those short BD operated eyelids. So I say, I try to stick to fat repositioning. If you have enough fat, if it looks like you have some, I will take some and I'll reposition it, and I'll fat graft you at the same time. Fat grafting at the same time as a lower eyelid surgery is a little more predictable because you've injected it and you go in surgically, you find your plane, you clean up anything that may be in the wrong spot. And I'm doing everything super periosteal anyway. So I agree 100% with you. And that's the way I explain it to people. I say, I can get you farther with a filler more safely.
Right.
Fat has a role, but I like to use fat for small improvements. If you want to look better, you got to use filler or do surgery, filler or surgery. Okay. Fat's for little adjunct, little bit.
Okay, good. Yeah. Okay. And that's right. And that's pretty much how I explain things to them as well. And then in terms of rhinoplasty, you're right. I do get that question quite a bit. They come in and they say, you know, I've been thinking about doing this with my nose. I'm thinking about getting rhinoplasty, but you know, I just wanted to take it out for a test drive and do some fillers first. Yeah. I'm like, yeah, it's not the same thing. It's not what I'm doing. What I'm doing, what rhinoplasty is completely different kind of procedures. Mm-hmm. And so some people are better candidates for what I do. Some people are better candidates for rhinoplasty. And then that's when I refer. But it's just, I think but it still is kind of, nevertheless, it's still kind of interesting because I still do have people who do filler and then are like, okay, now I'm going to go to rhinoplasty. There is some people who actually use it as a kind of a test drive, mainly because I think they want to see what would I look like with a different nose? What would I look like if I made my nose straighter? Mm-hmm. And then because, you know, again, I'm not physically reducing the size of anyone's nose, but I am making it straighter. I am making it look smaller. So they want to say, well, so I can tell them, you know, look, I will give you the effect of having a somewhat smaller nose by making your nose straighter, and see what you think. And so some people actually say, you know, I really like that effect. Now I'm going to Dr. Talei and getting rhinoplasty. Yeah. So,
thank you. So, so the way I have the conversation with them is, you could do filler, you can do rhinoplasty. I go, and I tell them they're two completely different things. And I try to be very dramatic about it with my hands.
Hand waving,
So they understand that the result is a different type of result. So you're not going for the same thing with either one. And I show them in a photo sometimes, like a quick morph. And because I don't like to spend a lot of time on morphs. I think it just like ruins my life. So you get people that focus on morphing. So I just show them, I go, listen, this is building it up, makes a small change. If that's the change you want and you'll always be happy with that and you're willing to come back every once in a while, I'm like, your nose is good enough. Don't even do the surgery. You know, really, we're just working on that lateral view, that little dot here. It's fine. However, proportionately, if you go actually do a rhinoplasty, it's going to balance your face out better. So for people who have harsher character,
Right.
I'm like, you can't change character
Right.
with filler. Filler is going to be very delicate character
Right.
change. Little shadow
Right.
here, little shadow,
Right.
little bump.
Right.
Real character changes from nostrils and like flaring and looking like that. And those kind of things you can't get with filler. And if I were you, I think you have, and I tell them realistically, this is how I see people. I'm like, you look so beautiful. You have all this really good structure. I'm like, and you're a nice person. You should look a little softer, and rhinoplasty is the better way. So if I were you, I wouldn't try filler.
Right.
Rhinoplasty is the only way I can see this really working well for you.
Right.
Either don't do it or do it right. Just wait
Right.
till you're ready to do it.
Right, because why waste money? You know, I mean, it's not free.
Yeah.
It's these are things that cost money, and also there's never nothing's risk free.
Yeah.
And nothing's consequence free. So
Correct.
do the right thing the first time.
And what if I do it now and I want to do my rhinoplasty in 6 months? I just want something to hold me over. Isn't the filler going to go away by then?
Not so much.
No. So that filler, even 5 years later, it can be there from the smallest injection.
Yeah.
So what about putting threads inside of your nose?
You know, I see that on Instagram. People do that. And I know some people, I mean, it's a hot thing apparently, and abroad in Russia, people do it a lot. Here they do it some, not as much.
I trust Russia as a country all the time.
Of course. I mean, what could go wrong? You know, I mean, you heard that their doctors have now taken into an interesting hobby, and that hobby is flying out of the hospital windows. Have you heard about that?
No, yes, I have not.
Doctors who complain about working under risky conditions because they don't have enough PPE. Here, they're just like, they go on Facebook, they complain, whatever, and they get, sometimes they get PPE and it gets them results. If you do that in Russia, you go flying out the window, apparently. And, and I think it's like 4 doctors have gone flying out the window of hospitals. 1 has survived. Yeah. So watch, so stay tuned, because chances are he's going to go flying out the window again, because once you get into the habit of flying out the window, you tend to like continue doing so.
Yeah, but that goes back to, I've been giving people this advice my whole life. I go, the only kind of Putin that you should be messing with is the kind with potatoes and gravy in Montreal.
That's right.
Like,
that's for sure.
Don't mess with the other one.
So I don't get threads, man. I don't. You can say it.
You can say it diplomatically. Go ahead, say you're diplomatic, and I'll say how I feel about it.
It's a quiz. To me, it's a quizzical thing to do. No, it's a conundrum to me why people would possibly want to put threads in the nose. No, it doesn't make that much. I mean, yes, I understand. I mean, do you use threads at all?
No, but I'm not against all threads.
So it's in the nose in particular, right? You're putting basically a piece of whatever it is, Sculptra, polylactic acid or whatever the thread is, underneath the skin of the nose. And you're saying that I'm assuming what you're saying is then that is a lifting mechanism for the tip. Because if you're doing it if you're doing it as an augmentation, when you've got all these great tools like, these filler tools around, and you're doing threads and augmentation, that makes no sense at all, because it's very imprecise. And so, that makes zero sense. The only way it makes any sense at all to me is if you're doing it to lift the tip. But even that makes no sense.
It makes no sense.
Because what do you're just letting this thing float underneath the skin. I mean, are you tacking it in? No, it's just floating there. It doesn't make any sense.
Yeah, I think the doctors that should be doing it, or are doing it, they should be writing children's books, because they have a very imaginative ability for things to work. And it reminds me, I'm really bad at analogies and comparing things, as you can tell.
You're very good at
but
it.
like, what comes to mind is Andrew Dice Clay. And Andrew Dice Clay, he said once, it's like masturbating with a cheese grater. He's like, amusing the first time, but painful in the long run. And so, you know, and I try to think, okay, what happens when you put in a thread? Maybe the first second you're like, oh, okay, it worked. But then now in the long run, when you keep masturbating with this cheese grater, what's happening is it's scarring things. It doesn't go away. Yes, the thread is there, and I get it. Everyone can excuse it by saying it's temporary. What's the worst that can happen? It's temporary. No, man. It's punching someone in the face gently.
Also
okay,
temporary.
It's temporary. Yeah, punching someone in the face by Mike Tyson. Yeah, it was temporary. But that person's damaged the rest of their life, and their face is going to have to keep recovering from it. A thread can do the same thing. A thread can incite a fibroplastic response where you have to go form scar tissue in those areas. Now,
are we going to get cut off?
No, I think it goes to 2 hours now. I don't know, but even if it doesn't, we can come back.
We can come back. Okay.
But let's say even if it didn't have that risk, then I'm like, dude, what are you doing?
Why would you do it? Yeah,
I still don't
make any sense.
Like what logically. You know, just because your photo might look good for 2 seconds, I don't understand. Like, how is that ever actually going to work? Have you seen a nose open? Have you ever opened a nose? Have you ever touched somebody's nose? It doesn't work. Now, I always qualify that with there is one exception, and that there are some doctors that I do trust who deal with breathing problems, and they have used the same types of threads from a different company, and they're PDO threads, and they put them in the nasal sidewall to help stent noses.
That valve. Yeah.
The valve. I'm okay with that. I'm cool with that.
Yeah, and that makes sense.
Yeah.
You can do You can do that with anything.
Yes.
Like you can stent that valve with anything. I mean, there's an early paper written right when I think it's an 04 or 04, 05, where they put radius to do that, injecting from the inside.
Oh, okay. So I'm scared of radius in the nose, but Dr. Miraz Robinson was actually on here. She's like professional actually gave me advice on how to get rid of radius, which is very difficult. Yeah, she does that sodium thiosulfate stuff. But I use radius very, very cautiously. I don't use it anymore, but when I used it, it was like just on bone. And I always tell people, I'm like, stay away from the nose. It's a calcium paste. It's a little scary on you can't get rid of it.
Right, and it's just, I mean, it's a very much of a radius. I mean, radius in general it's a specialty tool. It's just because it's not, you can't get rid of it. It's hard to get rid of. I mean, you can, with Deanne, you can with sodium thiosulfate, maybe you can decrease a little bit, but I think it's tough to get rid of, and it swells afterwards, and people, it's just tough. You know? So
and so with this stuff, also the excuse always becomes it's temporary. So it can be, fillers can be temporary, but even with the most delicate of fillers, we see it can last 10 years. And when you have something there that's inciting an immune response or a fibroblastic response, fibroplasia, you don't know really what it's going to do. So I do see that a lot with radius and the soft tissues, and people use that to their advantage with Sculptra. You use Sculptra to your advantage by forming scar tissue and granulation tissue, and it looks like gray, firm fat, and that does replace some volume. But let's say you're doing that superficially in the skin. Now you're dealing with calcification, discoloration, vessel formation, kind of all that stuff that happens. Do you teach people how to do the nasal injectable stuff?
I mean, I do.
Like, do you have a lot of visitors?
Yeah, I have people coming through. I have people rotating through, and I have people coming in who want to learn how to do it. I try to pick and choose who I'm teaching, make sure that they have the proper experience level with injections in general. Yeah. And I'm not going to say, and I think it's this kind of stuff. Whenever people start talking about this in a turf battle kinds of things, like, well, only doctors should be doing this, or only facial plastic surgeons should be doing this. It's kind of like, it turns me off, because people will do it. If they want to do it, they do it. So, and I think that, to my mind, I'd rather teach them than have them do it in a bad way and have something bad happen.
Yeah, I agree with that too. And the turf stuff never really made sense to me, because most of my complications come from doctors. So
yes, that's right. Mine too.
The nurses and everybody tend to be more conservative when they do it and if they do it. And certainly in LA, you do see more common sense, more good sense. I say common sense isn't common, but more good sense.
Yeah, exactly.
where, you know, there are nurses and nurse injectors, and some people who say, you know what, I won't do the under eyes. I just don't do it. And they're the idiots who like, oh, well, I don't do it because it's horrible. It's a bad thing to do. Or they're like, well, you know, I just choose not to do it. I prefer not to do it. And this other doctor does it. Or there's some people who same with lips too. And that's wonderful though, because if that word spreads amongst everybody training, they start to see, oh, it's okay if I'm uncomfortable doing something.
Right. Indeed.
I excel at what I'm comfortable at. I have no problems. Nobody hates me. Everybody loves me. Why don't I eat some worms? It's a good song. But
it is a good song.
Yeah. So, but that's really, really nice when you see that amongst the injectors, and they start. Every time I hear that from an injector, like if someone came to me and they're like, my injector sent me to you to do my under eye, to do my nose, to do whatever. I go, you have a very smart injector.
Right. And it's like, good for business too. Because then, I mean, it's just like, you know what you're good at, and you know, and why, and then you send to other people that are really expert at what they, in terms of what, and that's what I always tell people. They're like, oh, how do I choose somebody? How do I choose somebody? Like, you choose somebody based on what you want to do, and if they do what you want to do every single day, like every single day, all the time. If this is what they do all the time, and that's the person you should be talking to. You know, not if that's the only thing that matters. And if they're still, if they do it every single day and they're still in business and nobody's come around and shot them yet, chances are they're pretty good at what they're doing. So, you know, go with somebody like that. Yeah. And you can't be doing everything every single day.
Yeah. And so the big thing you see with Instagram, everybody sees these photos, and I think social media is wonderful for so many reasons, but the thing you see is everybody sees these photos and they say, oh my God, they're getting these results with injections. And I do injections. I could just grab a needle and put it in. I have the physical ability to inject somebody.
Right.
Not realizing how difficult it is to really be good at some of this stuff. I'd say, you know, with this stuff, never underestimate how difficult it is to make small changes. And we're not talking about one person. We're talking about, you treat 100 people, 1,000 people. How do you get success on all of them and then keep them looking good 5 years later, 10 years later? You know, a lot of these injectors don't ever think about longevity. They don't think about it. Like, they just, you know, they fix them there. It looks good that day, and that's it.
See you later.
And and that's how all this Juvederm shit came about with everybody in the under eye. They're like, oh, it looked great. What do you mean? It didn't cause a problem. 2 years later, they have another issue that's going on. You know, the injectors have to think a lot about longevity. And when it comes to nose, nobody should jump into it just thinking that they can do it. So this debate that everybody's always talking about with, it's dangerous, I never inject noses, it's dangerous. No, I can tell you a million reasons why the surgery you're doing is equally dangerous.
Of course.
It is safe in the right hands, and you know, you don't do this stuff without like a ton of training, I'd say. So we have some questions. Question one. So I mentioned that over the time the tip of the nose can swell a little, and what I was talking there was congealing. You've seen like when it congeals and it becomes translucent.
Yeah. Of course. Yeah. So can that be fixed? No. So you mentioned of course. I mean, if it's filler, no matter what, if it's filler, if it's a jelly, you can dissolve the jelly. Right. Yeah. So you can always put an enzyme in there, and you should be, you know, it should be okay. You know, any kind of filler complication like that, you should be able to manage. Even like, you know, under the eyes, you know, people swell up for 2 years, they're good. And then 2 years later they come back and they're all puffy under the eyes. Yeah. Oh, but it's 2 years later. It can't be the filler. It is the filler. And the nice thing about it is that we can reverse it. So,
yeah. And, you know, what I would say too, for nose filler specifically in the tip, the really cool part about a lot of the tip filler is you don't have to dissolve it. You can poke a needle in there, the same needle that you use to inject. That's true. You poke it and you squeeze it out, and you're actually not squeezing all of it and losing all of your tip support, which is great.
Right. That's true.
Yeah. So I think that's...
I don't know how you do that with the questions. It's kind of cool. Oh, it pops up on the screen. Whoa! Hey, there it goes again.
I'll teach
you.
Dude,
you're like the wizard. It's like a wizard.
So what about lymphatic drainage? And the only reason I bring this up is slightly unrelated to the nose stuff, but what about lymphatic drainage on people in general, post-surgical, or who have most of the time good under eye filler, but then sometimes it kind of wakes up?
I don't know.
Do you use it?
I don't know.
So there are people who I tell them under eye filler is imperfect, okay, and it can always have some reactivity, and some days you'll wake up and your body might want to draw in water to it. Right. If you're an allergic type person, or you drink a lot, or you have a lot of salt, or you lay flat a lot, these things can happen more often to you than other people. If it's happening once a week, once every 2 weeks, once every 3 weeks, who cares? You know, do some lymphatic massage, a jade
Right.
roller. Lymphatic massage, you're actually draining the water out of it. In 2 seconds, it's gone. Not 2 seconds, 1 minute, it's gone.
Right.
Otherwise, if it's happening over and over again, then you just shouldn't be a person who has filler in your under eyes.
Right. I think that's true. And that's something that I'm telling people. Yeah, I'm just telling people to massage it down. It's, you know, if it's something that keeps popping up every morning, you know, then that's something that we need to just kind of bring down a little bit so that it doesn't happen quite as much. But there's not a lot of ways to like really, you know, don't eat salty stuff the night before. That's one way. But
yeah. So here's another one: radius into hollow temples.
What do you think? You're like, no way.
No, yeah, I mean you can. That's the place where I'm okay with it. There, you know, when you take a dump that low deep in the face, there's not much that can go wrong with it. So,
I thought we were back to the shit on the face analogy.
No, this is.
I heard dump. I don't know.
If it's
right?
if it's deep enough in the face, yeah. So I have very weird shit analogies, unfortunately, because one of them actually I used the other week was, I remember when my brother was 5 years old and he went and took a little cocky in the middle of the street, and he was like, you know, so proud of it. And I think of a lot of these doctors like that, where they have these just terrible results and they don't know what's good, and they like go show their stuff and they're so proud of it. And I keep thinking of like my brother, so proud of the same exact. Yeah. So radius deep in the temple, I don't have an issue with, because it's a calcium filler. It can form calcium crystals, let's say, or it can stick around and kind of calcify tissue. Right. But what's that doing realistically if you're down in the deep layer of the deep temporal fascia? Probably no negative effect there. Now,
I got it. Yeah. No, superficially, it's not.
Superficially, it's horrible.
No,
superficially, forget it. Yeah, but superficially, why is it horrible superficially?
Because, well, interesting you asked me. Interesting you asked that question, sir, doctor. Because, you know, one of the things that I don't really love, I mean, I think radius, yeah, no, I agree. I really do. I agree with you actually in that sense, where radius in the temples, if placed very deep, I think actually does a good job lifting tissue. And especially if it's a very deep temple, if it's an indented temple and there's a lot of volume loss, it'll do a good job of lifting tissue from a deep plane. And what that means is then the tissue, if there's a big cushion over the radius, then the top result is still smooth. Because if there's one area that aesthetically speaking is intolerant of having any kind of like weird contour abnormalities, completely, the temples is it. Yes. I mean, if you put something in the temples and it comes out bumpy, everybody knows you've got crap in your temples, and and everybody knows you've gone to a crap injector. So it's really, it's very, like forehead's the same way. You have a bumpy forehead, like there's something wrong. Yeah. So you got to make, the radius superficially, I think, is in the temples. I think that's a big mistake.
Big, huge, giant mistake. You know? So the justification for it, or the rationalization from whatever, however you want to define these people, but they say that it's a white paste and it has a whiter look to it, so it makes the skin look brighter.
No way.
It's like the worst rationalization I've ever heard. The negative effects that can happen is you can get bumps, calcifications, nodular.
And you can't do anything about it.
You can't
like
fix it.
It's not like HA. You get a bump with an HA, you can fix it.
Now, what's the biggest problem I've seen there is actually venous engorgement, and I'm not talking about the good kind. I'm talking about this venous engorgement. So you have arcade of vessels that's coming down over here, veins that are very superficial. The second you massage them, you'll start to see them pop out. Right. Let's say you go put a filler there that's blocking the passage of one or irritates one. All of a sudden, all those veins above it start to engorge. And I've seen that on so many people who have had superficial fat injections, superficial radius injections, those two. Right. And they just get those permanently and they say, what can I do about it? I'm like, well, you can pray, but that didn't work so well the past 50 years and, during wartime. So it's and you can't fix it. So, but radius deep, I'm okay with. I don't use it. I just use Restylane Lift or Voluma.
Yeah, I usually use Restylane Lift and Voluma because I find that Voluma lasts longer than radius. Yeah. I think radius is like, I mean, I think it's also not true when people talk about how radius lasts for such a long, is a semi-permanent filler and lasts longer than other fillers. I don't think that's true. I think radius is a good tool, but let's be realistic about how long it lasts. I think it's like, I see a variation between 6 months and 12 months.
Yes.
And I can't tell who's going to be who and who's going to tell 6 months and who's going to be 12 months. But 12 months is, I don't see too much more than 12 months.
Yeah. And in the end, if voluma is sitting in your soft tissues, its bioactivity and ability to cause fibrosis is very low, or calcification is very low.
Yeah.
Radius sitting in the soft tissues don't want calcium paste in there. There's no existing calcium paste inside your natural tissues. Calcium paste should be near bones. So when you have Sculptra sitting in there, and here it was where I see it all the time from facelifts and muscles, it can actually change your muscle movement. And then when you're actually surgically going in to do things, it's concrete. So even though the result went away at 6 months to a year, you have this little tiny nidus of fibroplasia in there for years, for many years, or permanent. Whereas voluma doesn't do that. So I always look at the hyaluronic acids as a nice greasier kind of substance that causes less reactivity in your body in general. So that's why I stick to them. And then you have Sculptra, and Sculptra also deep. You can do it, and then you just wait for a long time for it to work. It's fine. I'm not a big Sculptra user, but certainly if you use it deep over there, you're not going to get many problems. The reason I hate Radius in this region is because I do a lot of brow lifts, and I'm trying to get a big brow lift, and I'm trying to save the facial nerve all the time, and it becomes very difficult in somebody who's had multiplanar radius. It's very difficult. You can't cut through it. You can't spread it. You have to it's very, very difficult.
Right. I mean, I think that's a good reason, because you never know. I mean, what do patients come in, I think they don't know if are they going to get a brow lift in 10 years later or 5 years later. And I think it's a good hedge to just use something that's as safe and easy as possible, permits them to, doesn't cut off any kind of options for them.
Yeah. So check that out.
back in the old days before COVID, right?
Yeah. So everybody knows Dr. Rivkin is like the nicest, sweetest guy, but he's also very impressionable. You can sit there and he sees me. Everybody accepts in the meetings that okay, well, Ben might have something good to say, but he's also a degenerate. But we'll listen because it'll be entertaining. And so but they don't know that between the sessions we go and try to have tequila shots. So this I think was actually probably around one of those times. where you said no and I said please come on just one.
It's bad influence. See, I mean, it's not only is it bad influence, but then immediately after that meeting I started to grow facial hair, and so and there you go. Now it's just, getting gray in the same places. So
same distribution. It's
right.
It's a match. All right, well, we'll finish up. So for everybody, Dr. Rivkin, it's Dr. Rivkin, Rivkin. He's not the dermatologist. He's not the dentist. He's not the dentist's brother.
Right. Indeed.
Yeah.
We should form. It's kind of funny to form a practice. Rivkin, and Rivkin. Because there's 4 of us. In LA. I mean, we could do it theoretically.
One more, and you'd be like the Power Rangers. I think. Yeah. Or is that 5 or 4? I don't even know.
I don't remember.
I dressed up as the fuchsia Power Ranger. I made a new one. Yeah, it was a fuchsia Power Ranger.
That's a good color on you, I'm sure.
Yeah. It was Franny, the fuchsia Power Ranger. Didn't want to fight crime anymore. Got tired of fighting crime and just wanted to be fabulous. So it was the fuchsia fabulous Power Ranger, and I was filled with I was filled with glitter. So for everybody who wants to follow him, he's Dr. Rivkin, Rivkin, and he also has West Side Aesthetics, which is it's a very gangster kind of name. I tell people.
We do this kind of, I don't know what it is. Something. Yeah. We do something as soon as every day. Come in. Start doing this kind of stuff. I don't know.
All the good stuff. Yeah, it's where Tupac used to go. It's the West Side Aesthetics. Yeah. It's fantastic.
We weren't involved. We're innocent. Nothing. We weren't involved in any of that stuff.
Yeah. So anybody wants to visit him, he's there, and then we'll have this podcast up probably in about a week or so. If you guys want to watch it on the Reality Pill page and YouTube and everywhere else, so you can keep looking at that face. All right. So thanks for tolerating me again.
Thank you. It's a pleasure. Thanks for having me. And thank you guys for tuning in.
Yeah. Take care, everybody.
Take care. Bye.